models. You've already been doing that. You need to collect natural history, meaning understand what patients' lives are like, even if they're not treated. You need to try to understand the mechanisms behind the disorder. You need to try to understand what the daily life is like for families and caring for people with the disorder and for people with the disorder. You need to come up with biomarkers. And right around at this part of the process is usually when these fabulous ideas for treatment happen. Once you start learning about the mechanism and learning enough about the actual disorder, you can start coming up with treatment ideas. And then once you have your biomarkers identified, you can actually start also working on getting these treatments tested in animals and trying to measure whether these treatments could be effective in people with outcome measures. And that's when you can go to clinical trials and head to the FDA. So this is what we do at COMBINEDBrain. We try to help all of these steps in the process. And really everything above the blue line is really the responsibility, well, and the power of the patient advocacy group, of iDefine, and the patient advocates themselves. And everything below the line is normally the responsibility of academics, of researchers, and industry, but none can live without the other. So everything above the line contributes to everything below the line, and everything below the line depends on everything above the line. So what we try to do is help the patient advocacy groups get the work done above the line and help industry and researchers get all the resources they need to get their work done that's happening below this line. So these are the members of COMBINEDBrain. And this actually list is a little bit out of date. I think we have about 30 more members now, and I need to make a new slide. But the whole idea is that we have a lot of member organizations, and all of these member organizations have a lot in common. So we launched in order to learn from Angelman syndrome. And so we really looked for disorders that in many ways were similar to Angelman syndrome. And the reason for that is because there were already a lot of research opportunities for people with autism. And there were actually a lot of research opportunities for people with epilepsy. But there weren't a lot of research opportunities for people that just had cognitive disability. And so we really tried to focus on disorders that had cognitive disability as a number one sort of core symptom. Of course, you can't separate out any of those. So all the groups that have these disorders will have a component that has autism or autism traits, and all of them will have a component that has some epilepsy or some kind of epileptic activity. But they're all unique too. And so at COMBINEDBrain, the trick is we want to know what we have in common, what we can share, and also what's completely unique about each specific disorder. And I was listening to the presentations this morning, and you know that Kleefstra really does have unique aspects, cardiac aspects and other aspects that really make it stand apart from some of the other disorders. Okay, so how do we get clinical trials to succeed? Well, let me tell you. What we learned in Angelman syndrome, so back in the early days when my son was diagnosed and we were trying to get these compounds into clinical trial, what we realized is that we were doing a great job at treating mice. We were doing a great job at curing mice. Mice were the center of the whole process. We worked on the mice in the lab, and then we treated them, and then we looked to see if they did better on mazes and building nests, and standing on, balance beams and rotating rods. And then we then went to clinical trial to see if we could use the same compounds in people. And guess what happened? Our clinical trials failed. Not one, not two, but 3 clinical trials failed. That's because we were treating mice instead of treating people. And so one of the big lessons I learned was that we need to start with this revolutionary idea of having people in the center of the process. So what we need to do first is find out what matters to patients, and then collect natural history based on what matters to patients, and then measure that in mice to see if those things are something we can see in mice or not. And then we can come around to endpoints and looking at outcome measures, and that will help clinical trials succeed. Okay, so this is, you think, kind of a silly idea, maybe not that revolutionary, but in fact, it was revolutionary. Not COMBINEDBrain didn't have this idea. A lot of people had this idea, including the FDA. And in fact, the FDA, since 2017, has really had a breakthrough in the whole notion of patients being in the center of drug development. And they've published 1, 2, 3, 4, 5 guidances that try to show industry and researchers how to actually get patient input in a very scientific and rigorous way that can then be used for drug development and for designing clinical trials. And hopefully we'll be able to then get more drugs passed and approved, especially for neurodevelopmental disorders, which are notoriously hard to measure. So one of the first things to do is to find out what really matters to patients. And how do you do that? Well, this is the interesting part. You ask them, you ask patients and their families what matters to them. And you all have a disease concept study going on right now, and you're going to hear about it today. So I'm not going to go on in too much detail about disease concept studies, except to say that they're crucial. And in fact, for Angelman syndrome, when I first was organizing the Angelman Biomarkers and Outcome Measures Alliance, I was called on the phone by a big pharmaceutical firm, and they told me, cease and desist. And I said, what? What? And they said, stop everything. Before you go any further, you need to do a disease concept map or a conceptual model. You can call it either thing. And so I thought, this is ridiculous. At that point, we'd already been collecting natural history for Angelman more than a decade. I myself had interviewed personally probably 135 families and kids with Angelman syndrome. I had a kid with Angelman syndrome, for goodness sake. I knew everything about Angelman syndrome. And in fact, I'd already gotten a PhD in Angelman syndrome as well, in neuroscience. And so the whole point is, what did we possibly have to learn? But I said, okay, what do you want me to do? So they wanted me to come and listen to a presentation about disease concept maps. They flew me and several other patient advocate leaders to hear a presentation. They gave us this whole presentation, and I thought, okay, that's great. We'll do a disease concept map, but what do we really need to know? We already know everything about Angelman syndrome. And then all of us at the end of the day, we had a very nice lunch, good discussion. At the end of the day, we got on an elevator, all of the patient advocates, and went down from the top of this tall building to the floor. And as we were on the elevator, all of us were texting our caregivers, our husbands, our babysitters, whoever was at home with our Angelman kid. And guess what? All of us were texting about gastrointestinal issues. And that had never been studied in Angelman syndrome. it had never been mapped on any kind of a concept map. It wasn't even mentioned. And so I realized they were right. You actually have to ask people what matters to them. And so we did a conceptual model of Angelman syndrome. And in fact, two were done in a short period of time, one by Wilgas et al., one by Greco et al. And they actually have a lot in common, but there are a few differences. But since then, all of the drug development efforts in Angelman have been based on these disease concept maps. So when we launched COMBINEDBrain, we did draft disease concept maps of all of the original 20 disorders. And draft disease concept maps, that just means you do a literature search. You're looking at the published literature. But what does that mean? That's what doctors care about. That's not what people care about. What's published in the literature is often what's seen the most severe symptoms. It's what the medical profession and scientific profession has identified about a disorder. It's not what families see in their kids and what families live day to day. But we did draft disease concept maps anyway as a starting point. And then that's what you use for your starting point for your conceptual model. Then you do open-ended interviews and you just ask people to tell you about their day, tell you about their nights, tell you about meal times, about, issues that they have, anything they want to tell you in a very open-ended way. When we did these draft conceptual models, we then merged them all. So we took all 20 draft conceptual models and merged them. And when we merged them together, they told us what the medical establishment anyway cared the most about each of the original 20 members. And so what you can see is that even a draft conceptual model is helpful, but a full one is even better, which you all are already doing. So what we found with our draft ones is that communication was a huge domain of disease for 20 original disorders in COMBINEDBrain. So behavior was also a big deal. Cognition was a big deal, obviously, because we had specifically searched for disorders of cognition. And even though seizures were important, they weren't as important as communication if you looked across the board. So at COMBINEDBrain, the first thing we did was say, okay, what can we learn from, and how can we expand what we know from Angelman across other COMBINEDBrain disorders? So communication had also been the number one concern for families with Angelman syndrome. And so the Foundation for Angelman Syndrome Therapeutics had actually commissioned an outcome measure called the ORCA, Observer Reported Communication Abilities measure, which is a survey of parents asking about their kids' communication abilities. The reason that FAST had commissioned this is because all of the other measures of communication were too advanced for people with Angelman syndrome. They all scored below the floor of those communication measures. And so even if they improved at communication, they still wouldn't reach the floor of the measure. And so you wouldn't be able to tell that they had gotten better. And I know, as the mom of a kid with Angelman, that even if he could just communicate a little bit better than he does, that would improve his quality of life and our quality of life. So they had come up with this ORCA measure for Angelman. So what we wanted to do then was expand that to a lot of other COMBINEDBrain disorders. So along with this crack team at Duke, led by Christy Ziegler and Bryce Reeve, we actually are expanding the ORCA to 12 other neurodevelopmental disorders, and they span a pretty wide spectrum of severity. So hopefully by the end of this whole study, you'll be able to use the ORCA for Kleefstra too, and for other neurodevelopmental disorders. So how we did that, we took those draft conceptual models And we tried to say, okay, which are the most like Angelman of the 12 disorders, and which are the most different from Angelman? So we started with the ones that were most Angelman-like, which is SYNGAP1 and STXBP1 among these 12. And then we moved further and further away from what is most Angelman-like. And so you can see how even just that draft disease concept map helped us design the study of the observer-reported communication measure that we're hoping will be able to be used across all these disorders. And then more plugs for disease concept studies. So we then began to work with genetic counselor master's degree students. And we worked with a team at Children's Hospital of Philadelphia under Ingo Helbig. And the student was named Katie Rose Sullivan, and she also worked really closely with Sarah Ruggiero. And so what we did was help them construct a conceptual model of STXBP1. And that was actually really important for STXBP1 because they found, this is my favorite figure from the paper, and this paper was published this year. What this figure shows is that families' concerns change a lot over the age span of the kid. Okay, duh. I mean, a lot of families know, obviously, that what they're going to worry about for a baby is different what they're going to worry about for an adult. And so it seems obvious, but it's not always, because if you just go back to the literature, what you're going to see about STXBP1 is that seizures are the most important issue in that disorder. But in fact, if you look at this figure, and this dark blue shows how important seizures are, or how much of a concern seizures are at the different age groups. What you see is that they're a big concern in infancy, and they're a concern also in adulthood. But in fact, they're not very much of a concern in school-age kids. And that's really important because most clinical trials are going to be aimed at kids that are already diagnosed. So they're going to be 2 or 3 or 4 years old, and before they hit puberty, when you don't know what's going to happen with seizures and all kinds of other healthcare issues. But if you look there, they almost have no seizures. So in fact, if you're measuring the effect on seizures in that age group of kids, you might not even see that the drug's working. And look, behavior at that age is really a concern. And so, in fact, if you're looking at behavior instead of seizures in that age group, you might actually be able to detect whether a drug is really working or not. So all of this comes from the disease concept model. We also work with a company, which is a for-profit, a B Corp, called the Trend Community, which is actually run by a patient advocate who's the mom of a kid with Prader-Willi syndrome. The Trend Community hops into your social media if you give them permission and looks at the conversations in your Facebook group or your Instagram or whatever you use, and looks to see what people's concerns are over time. So it's a way of continuing your conceptual model as things change without actually having to do a whole big study every few years. So what we did is then is not just show how disorders are similar across communication, but also we can look and see how disorders are similar across all of the domains of disease. So this again, this is again is a map of our original 20 members mapped to each other. And so what you can see is which disorders are most like each other. Well, we wanted to be able to do this about all of our 80 combined brain disorders. And now we're doing full conceptual models, and Kleefstra is doing a full conceptual model. So we want to be able to merge all this data into one big, giant conceptual model database. So we're actually working with CHOP and with all the different teams that are working on conceptual models so that we can actually put all the data in one place and be able to compare all these 80 disorders to each other, or 100. We're almost up to 100 now. And so that way we can design better outcome measures, better clinical trials, maybe even come up with compounds that might treat domains of disease across disorders. So these are the genetic counselor student projects that are going on right now. And we actually have 4 new ones just added in the last month. And so what you can see is there are a lot of disorders that are being studied across a lot of different institutions. And it's really exciting to be trying to work together on a unified way of doing this. Okay, so what else are we working on at COMBINEDBrain? Well, we surveyed our patient advocacy groups to find out what their priorities were, and their number 1 priority was biomarkers. The number 2 priority, if you just ask across patient advocacy groups, was natural history. And the number 3 priority was research strategy. So we definitely are concentrating on those 3. And what's interesting is that if you ask our industry advisors, guess what? Their number 1 priority is also biomarkers. Their number 2 priority, if you look across the 3 choices, is natural history. And their number 2, and their number 3 is just finding patients. So those 4 things really are our top priorities at COMBINEDBrain. And then when you ask the clinician advisors of COMBINEDBrain, it's pretty similar. Number 1, biomarkers. Number 2, natural history. Number 3, patient identification, just finding patients. So we have a lot of biomarker projects, and I'm going to talk to you about those in a minute. We also have natural history data collection projects, and I'm going to talk to you about those too. We are pushing to publish because it's very important to publish on everything we do and get it into the literature so that it can be used by a lot of other groups as a basis for their natural history, their clinical trials, and their drug discovery efforts. So right now we're ready to submit a manuscript on our biorepository. So we opened a very special biorepository 2 years ago. And in just 2 years, it's special because it's patient-led. The samples in the biorepository are, technically speaking, governed by the patient advocacy groups that recruit the samples into the biorepository. So this is different from any other biorepository. It was only launched 2 years ago. Our first sample came in September of 2021, and we're already up now to 550 individuals represented with over 5,000 actual tubes in the biorepository. We collect patients and controls. We have a national IRB, so we can collect from anywhere in the country, but not overseas yet, I'm very sorry to say. We can accept transfers in from overseas, but we can't collect overseas. We have done a couple of international collections, but they're really special. We can send mobile phlebotomists to your house to collect, or you can go into Quest Labs, or our favorite is if you walk into any COMBINEDBrain Disorders Family Conference, you can walk right in and give your sample collection there. We also coordinate with the University of Maryland Brain Bank in case someone passes away and they want to donate their brain or organs to science. We coordinate with them so that you can have that data connected to the other data in the biorepository. And we accept transfers in of cerebrospinal fluid. We also make iPSCs, and we have already 36 available iPSC lines, but we don't like to be redundant. And so the Simons Foundation will make lines for free for many of our disorders. So we try to coordinate with Simons and not remake any line that they've already made. So any patient advocacy group that's part of COMBINEDBrain can have an iPSC line made through COMBINEDBrain if they wish. All of this, it was one of those field of dreams, building the biorepository and the iPSC bank. if you build it, they will come. And so industry took notice. And in fact, we have 2 pre-competitive biomarker projects. One is completely funded by industry partners. One is actually funded by COMBINEDBrain. And these pre-competitive biomarker projects are projects that use the samples in blood, specifically in plasma, across all the combined brain disorders that are participating to look for biomarkers so that we might be able to measure just by a blood sample whether someone is responding to treatment. These are pilot projects. It's not going to be fast. They're going to take a while. We need a lot of blood samples from each of our groups to do it. And our pre-competitive industry-sponsored project ends in December. So if you want to participate in that, please walk into one of the COMBINEDBrain roadshow sites anytime between now and December and make a biospecimen donation. It will be governed by iDefine, and iDefine will be able to decide where those samples are sent and where they're used. So these are the list of the remaining sites. We've been doing this all year since March, but we have a site in Denver this weekend, San Antonio the following weekend, Washington, D.C., Seattle, Los Angeles. The exact date isn't set yet, but it's the end of October. Miami, also not completely confirmed, may be happening. And then in Orlando in the beginning of December. Otherwise, you can have your organization can have a mobile phlebotomist go to your house to collect the specimens, but they have to pay for that. It's not that much money. It's $250 or something. So you can't do biomarkers unless you know how severely affected the child is. You have to know if the child's having seizures. You have to know if the child's on a special diet. You have to know what medicines the child is on. So we have to have all that data collected too. And we're collaborating with RareX and with Simons and with Citizen too. But we have our particular surveys are on the matrix. And the matrix is really special. You can actually access it for free through the COMBINEDBrain portal. I can give you that link if you need it. And you can also collect really cool information just specific to your own kid that you want to collect. So I can give you more information on that if you'd like it. We connect all these things with the CRID, and you get that clinical research ID number through www.thecrid.org. It's free. Everyone should get one and then use that number, which each patient has their number, their own number, and they can share it with whoever they want. We're using that with Simons and with RareX to be able to link the data together across platforms. And then we also found from all of our disease concept studies that toileting was a really important domain for most of the families in COMBINEDBrain, but there was not a good way to measure improvements in toileting skills. So we've come up with a survey and we'd really like you all to test it out. It's already in the pilot phase right now, and it will soon be ready to send out to you, all of you, and we would love for you to test it and then tell us what's wrong with it and if we need to ask better questions or ask the questions differently so that it'll really capture what your kid can do. And as far as getting diagnosed, we have 2 big projects. One is we're partnering with Beginnings, which has a universal newborn sequencing project for babies born in San Diego and Memphis, Tennessee. And so any baby born in those 2 places has the option of getting whole genome sequencing. And we are working really hard to have all the combined brain disorders included on that sequence and reported back out so that we can actually identify kids right at birth. But you can imagine that's a complicated situation. So happy to answer questions about that. We also have a project called Project Find Out, where we're trying to identify babies between the ages of 3 months and 12 months that do have some symptoms, that something's the matter, but nobody's sure what. So feeding difficulties, movement problems, developmental delay, any kind of malformations, heart problems, seizures, or any admission to a NICU, and muscle tone. If they have any of these, two of any of these issues, we have a project to give them free whole genome sequencing, and we're doing that through COMBINEDBrain. So if you have any way to publicize that, these are people who don't have a diagnosis, who need a diagnosis. And then we're also creating an EEG bank. And this is also a lot like the biorepository. It'll be a patient-centered EEG bank. We'll be able to collect EEGs that you've already had done at your doctor's office or for any other survey, study. But we're also going to be sending people to your home to collect EEGs at your house, and hopefully to study novel technologies alongside, like some of the new technologies that can measure sleep and seizures without actually touching the kid. And then ICD-10 codes, we work on those. You all will hear a lot about that. And I'm so excited and proud of the ICD-10 efforts. And I know that you're going to hear more about that, so I'm not going to go over it. We try to help other groups to get ICD-10 codes, and many of them have been deferred. So ICD-10s are really important and help you find patients. And then I'm going to quit because we're almost done and I didn't leave any time for questions. We have a Rent-A-Brain program so that you can rent our scientists and postdocs to help out with your grants or your experiments or your analysis or anything else you need help with. This is our staff. We have a lot of students who work for us. They're amazing. Some of them are pre-med, some of them are in their gap years between college and medical school, and then we have postdocs who have finished their PhDs. So we have a lot of staff to help you out, and they can help out with strategic research planning, which I don't think I define needs, but we do help a lot of other groups with that. We help people get grants to get more mouse models if they need it. And then we try to publish and get our posters up to get the word out. We have a lot of funding sources. And the whole point is that we're putting the pieces together. We're all working together to try to put the puzzle together and figure out how to help each other. So that is my presentation. Sorry I went on and on. Let me see. It looks like I didn't have any questions anyway, so it's all good.
I don't think you went on and on at all. I think you covered a ton of ground. I mean, it's phenomenal what a resource you've built with COMBINEDBrain. I mean, I know that's the sentiment amongst all these patient advocacy groups that are a part of COMBINEDBrain. I mean, it's a pretty cool collection of groups that are informing each other, advising each other. There's a lot of benefit just by having those discussions at the monthly board meetings. And we've referenced Combined. I do. I feel like almost weekly, monthly. I think we're always talking about we're doing this with COMBINEDBrain. We're doing this with COMBINEDBrain, but it can be a little bit redundant. But the amount of information you just hit on there, I think, showcasing the partnerships and how you're partnered with RareX, you're partnered with Citizen, right? The biorepository roadshow effort that we are, I feel like just constantly promoting because it's such an incredible opportunity. I mean, I don't think, I don't know that I've done it justice. I know Eric hit on it, you've hit on it, really Yael hit on it yesterday. It's just not an opportunity that's available very often, right? To have something like this where we could go into a conference and this exists at the price point, for the lack of a better word, that it exists at. I mean, it would be a Herculean effort where we would be dedicating a lot of financial resources and as an independent organization pursuing this. And this opportunity is available where literally this weekend, if someone reached out to unlock@idefine.org right now and said, I want to participate in the biorepository roadshow in Denver or in San Antonio, whatever the case may be, we get you plugged in with the Combined Brain team, and it goes from there. So literally after Eric kicked off the conference yesterday, I know I have 3 email follow-ups about it. I'm glad you referenced the international effort that it is. Like, we don't go overseas, but we did have someone reach out from Canada. So if that's an opportunity, we've also referenced the opportunity with our partnership at Boston Children's Hospital with the Kleefstra clinic there, where we can help collect samples there. So again, this opportunity is a very big one. And it's also a very finite one. It's, through the end of this year. This isn't just kind of an open-ended opportunity. This is something where we are imploring the community to act, because once this opportunity passes it by, I don't know that something like this ever comes back again. And I don't want to miss out. Right. And so we don't have the in-person conference this year. I know at the last Combined Brain meeting, Kristen showcased that, KDVS, Poulin-de-Vries syndrome, which also was discovered at Radboud. So there's a fun connection there, and we connect with them often. But they're the leader in the clubhouse with, I think, almost 50 patients enrolled or having submitted samples, which is fantastic. And so, again, to the previous conversation with Citizen about the community, when we have these opportunities, it's incumbent upon us to have a response, and that shows that we are an engaged community. So Terry Jo, you're amazing. Thank you so much for all your contributions, not only to Combined Brain and to us, but the entire rare disease space. We're fortunate to have someone like you advocating on all our behalf.
Thank you. I really appreciate that. It's really nice. And yeah, I hope you get more samples than KDVS.
Me too. It would be fantastic.
That's what it's all about. So
Awesome.
thank
Thanks,
you
Terry
so much.
Jo.